First of all, I apologise for you having to listen to me immediately afterwards, again. But completely different topic. So let's just forget the previous. And for this, this is about challenge. It's about each of you individually thinking about what you say to people and what you include maybe in training or what you've heard other people in your organisation say in their training. And I just want to challenge you. So if you think I'm being a little bit controversial, then it's deliberate. I'm not being opinionated about it particularly. I just want to challenge held beliefs. And for this, I'm sort of putting my clinician head on. I've been an MSK physio for 41 years, and you can't really, despite all my passions for movement handling and all the experience in that field, you don't really ever stop being a clinician. So I want you to think and then go away and think some more. So I'm just going to challenge you a little bit. So, back pain in the workplace. You know how big the problem is and how big it's been for a long time. So these are figures from 2019, which is pretty up to date if you think about what's happened since. So in human health and social work, musculoskeletal disorders accounted for 32% of ill health. There are estimated 60,000 work-related cases of musculoskeletal disorder, new or long-standing, which is about a third of all ill health. If you look at the graph of this century, it sounds a funny thing to say, but that's now 21 years. So in this century, then MSDs have gone down slightly. There is a downward trend, but it hasn't gone. It's plateaued, but it is going down. It's certainly not going up, but it's certainly not dropping. It's a steady decline. And we could have a big discussion about why that is. Is that compliance? Is that equipment? Is that better management systems? We could think about that, but we're not here to do that. However, stress, depression and anxiety has 92,000, so a third more again of work-related issues. And I don't know whether you would think that that is reflected in your own organisation, but certainly it's around half of ill health in our sector. So if you look at a similar graph, then that's higher, not going down, but in 2018-19 didn't go up either. But I suspect if we could see that graph for the last year or two, then we would see a steep increase. I don't know that we would, in musculoskeletal disorders, save that of Zoom postures, possibly. So the extent of the problem is huge globally. So back pain is extremely common. It's experienced by people of all ages, peaks in midlife, more common in women than men. So across the world, there are a lot of cases. There are some seats down at the bottom. I don't pick on anybody on the front. So we have seen an increase, but then we could say there's been an increase in sedentary behaviour, we could say that we've had an increase in size, we could say all sorts of contributing factors to that. Back pain treatment in the UK costs more than cancer and diabetes combined. Back pain doesn't kill, but it places a huge burden on people and societies. Almost everyone experiences back pain during their life. How many of you have ever had back pain at any time during your life? Okay, I think that speaks for itself. Most people report significant improvement within the first 2 weeks, and 85% are fully recovered within 3 months. So why do we throw so much money at it? It doesn't kill us. A very small number develop long-standing disabling problems. So we know that we have our balanced approach to risk assessment. We know that the health and safety of our staff is 1/4 of that. So how many of you in your training programs spend just 1/4 of any session on back pain, posture, injury? How many of you might spend more than that or less than that? So we've just been talking about person-centred policies, and you all know what those are. Person-centred policy concentrates on the person being moved and also brings into consideration all of those other things we've just talked about in our session on HOP7. So risk assessment, equipment selection, communication and training, mentoring and in-work support, all of which are required. And also, as we've just talked about, the system to support that requires that triangular synergy, which is an ambition that every organisation ought to strive for. Back to back pain. So if there is so much back pain in the workplace, and if we spend so much money on it as a country, as the world, separately, are we, do you think, part of that problem? And if so, how and why? And if not, why not? So I want you to ask yourself that. Are we part of the back pain problem? It is true that people with back pain hurt, have discomfort if they're lifting something heavy or not heavy, or just a tin off a shelf, or a box or a bag off the floor, or turning around to pick your handbag from behind your driver's seat in the car. We have pain, discomfort. Perhaps we still hear phrases and sentences like, well, I guess I've come to your session today, but my back pain, I've got back pain. It's years and years of being in this job and lifting all wrong, all that time. Lifting is dangerous. Oh my goodness. We have to be careful how we bend. We have to really be careful. Bending is so bad for you. It's really bad for your back. You mustn't bend. Keep your back straight and bend your knees. If there was one phrase from the English language that I would like to get rid of, that would be it.
Mum, you know it was a Scottish physio that came out
I
in
do.
the 1950s.
I do.
Naughty mum.
Yes. If you do it like this, you know, you're going to be fine. Hold like this, put your feet here, bend like this, and you know, you'll be great. That's exactly what you need to do to stop yourself being injured. Oh, but you know, if you do it like this, you're going to be hurt. It's no doubt about it. You mustn't do it like that. I've even heard people say, you only have one back, so please look after it. I hope none of you include these training sessions. If you use bad postures, you will be hurt. Now actually, none of those are true. And you probably know they're not true in the back of your mind. But we've got to change the perception of the people we teach. And that's the hardest thing to do, because they come with ingrained perceptions of how difficult their job is and how likely they are to be hurt. Because bending is bad, and lifting is bad. And don't bend, and don't twist, and don't do this. Oh yeah, you're going to the gym on the way home. Yeah, so am I. There are perceptions and strategies that are increasing this problem or decreasing this problem. Scans. All my patients who have back pain want to scan. They want to know what's wrong with them. So I'll have a scan. Well, can you organise me a scan? Scans are increasingly used, but often, very often, they just don't help at all. Physical activity, yeah, it can be painful and frightening, but stopping physical activity is a much worse idea. That's horrible. That's much worse. Back pain is not all in your head. I'm not for one second telling people that they dream up their back pain. But their emotions and their reactions to their back pain change the volume of that pain. Turn that volume up or turn that volume down. And when the volume is up, then you have fear avoidance and do nothing. So then you're into a decreasing spiral. But preventing back pain sounds great. But actually, it could be part of the problem. Because you're highlighting things that where people are in a fear avoidance situation amplify even more. So let's look at each of those. Scans are increasingly used but don't help. So people want scans because they think they're going to get a diagnosis. But often they will show something really significant in only about 5% of cases. So 95% of scans are not showing anybody anything significant. However, they do show something. And if we have the opportunity to scan every person at this conference who was over 50, then 90% of them would have a bulging disc. Oh, I've got a bulging disc. I've got narrowed space. That's normal. We all have them. It's part of life. Do they show us any symptoms? Occasionally. Do they show us any significant symptoms? No. So over-scanning gives somebody a problem that they now think they have. Scanning's not the answer. They do, however, show these issues that people aggravate. People now think their back is damaged, leading to fear, distress, lack of movement, and they're into their downward spiral. Perhaps all of us, healthcare professionals, manual handling advisors, health and safety people, I don't mean that all health and safety people, should be careful in sending people for scans, for asking people for scans, because they might find something that is going to change the way the patient perceives their problem. People with back pain need to understand. Now, physical activity is painful, but stopping is a bad idea. What I want you to think about is, oh, sorry, I'm going out, I'm walking, you told me not to walk. Sorry. Am I all right here?
You're fine, yeah.
Okay. So I want you to think of back pain as like a sprained ankle. If you have a back pain, a sudden back pain, you've just gone over on your ankle, it's just in your back, okay? You've got a sprained ankle. Oh my goodness, that hurts. Oh, can't put my foot down. That really hurts. Swelling, pain, inflammation. Oh dear, I'm going to have to sit with my foot up. Put my foot up, put ice on it for a couple of days. Now, I'm not going to stop going to the kitchen, am I? I'm not going to stop going to the bathroom. Maybe I'll stop going to work. I do my best and I hobble on it because I know it's going to get better. I hobble a bit more, I hobble a bit more, and you know, it's now a lot better. I can still feel it a little bit, but you know, I'm walking a lot better now. 2 weeks down the line, oh, I still feel it a little bit at the end of the day. Still swelling a little bit if I walk too far. 6 weeks later, it's gone. Most back pain is a sprained ankle in your back. Please describe it to people like that. Let them hobble. Let them rest here and there. Let them understand that that is a good pain. It's getting better. And it will ease and ease and ease and ease until they can't feel it anymore. And occasionally they'll think, oh, you know, I go over on that ankle ever so easily now, but it gets better in a few days. I know it does. That's the attitude that we're looking for with back pain. So there's no evidence that any specific movement, any specific posture is either good or bad. All forms of exercise help, as long as people maintain that level of exercise through their healing process. Back pain is definitely not in your head, but thoughts and emotions are very important. the way we think about back pain, the way we react to back pain. It leads to sleep deprivation, anxiety, fears, mood swings, poor relationships. That gets into this decreasing process. Now, many of you will know that this is a biopsychosocial model. The bio is the sprained ankle, the swelling, the inflammation. That's the biology. The psychology is how you react to that. It's what do I think about this sprained ankle? I tell you what, I'm not going to walk on that again. I'm not going to walk on that for 6 weeks. And when I do, it's going to be so stiff. You know, I've got an ankle, I've got a problem for life. I'm going to have surgery on my ankle. Well, you don't do that. But people do with their backs. They tell you stories about their backs. So that's the psychology, and the social bit is, well, yeah, I've got to go to work, because if I don't go to work, I need to be at that meeting, I need to do that, I need to get there, I've got a sprained ankle, I can hobble, and you know what, I'll take a stick, because I need to go to that meeting. I can put my input in, even though I'm hobbling a bit. Back pain now. Can't do that. Can't come to work, I've got a bad back. Prevention sounds great. So, since some people with back pain, it can be disabling, and it certainly costs a lot of money trying to prevent it, don't we? We look at workstation design. We look at chairs, but you know what? Movement every 20 minutes is better than any chair. Some of you are nodding, some of you aren't quite sure. But I bet those of you who've been delivering training on Zoom are more tired than if you've been leaping around the room all day. So, most attempts have failed to prevent back pain because it's part of life. Approaches may have made people unnecessarily worried about everyday tasks like bending, lifting, sitting. Particularly if they've heard it in your training, not you, one's training session, where they've spent their time drawing a picture of the spine and telling them all about these 7 vertebrae in the neck and these 12 in the thorax and these 5 in the lower ridge and there's this disc in between and they move like that. And if you hurt it, that's it. How many times has that been the initial introduction to moving and handling, which is about risk assessment and balanced decision making and empowerment and person-centred care and quality? We've got ourselves into this pattern. Now, I may be controversial and I may be challenging you, but it is evidence-based. And everything that you will find, new evidence everywhere about the catastrophisation of back pain and the effect on society. So when you get the access to the presentations, then please spend time to look at the references. Think for yourself. So this is very poor on this slide, but if you get that on the evidence, then these are really good posters. Really good posters to print out and put on staff room walls, to use in your training, to use as handouts. This is changing the perception of back pain and where it sits in your training program. So, pain equals damage? No. And lifestyle factors important. Pain does not equal damage. If it hurts, relax, breathe and move more normally. Not lie down in a dark room and don't come back. So, I'm just going to tell you Lisa's story. I am just going to move here for a moment. So Lisa was a 58-year-old nurse. Now this story is written by a physiotherapist who I know, he's a very good clinician, writes a lot of stuff about back pain. So he's called Matthew Lowe. 58-year-old nurse with intermittent bilateral thigh pain to the knee was referred to his clinic. Her main complaint was a recurrence of persistent low back pain. She had already undergone investigation and her MRI showed a healthy spine, albeit with some bilateral lateral recess narrowing at L45 with a type 1 modic change around the vertebral end plate. She could quote that word for word. It means a little bit of wear and some degeneration. Okay, it's normal for a 58-year-old nurse. The first line says shows a healthy spine. She could only quote the second part. I remember treating this patient 6 or 7 years ago. Lisa worked in a care home and was a stoical type. She had endured many difficult medical and social situations. She had a history of breast cancer, and since I last saw her, she'd become pre-diabetic, put on a lot of weight and was smoking. We had got on really well last time and she made a good recovery, but this time it was different. I asked her how she was doing, knowing full well she was clearly struggling. Her reply was, not so good, as she lowered herself into a chair with a pained grimace. I sat opposite her and invited her to tell me what had happened since we last met. I kept quiet and concentrated on her story. Over the past 5 years or so, the periodic back pain that Lisa had suffered had been minimal and not at all intrusive. She had felt in control of her symptoms, she understood a lot more about how it affected her and what she could do about it, particularly during the odd flare-up. She would take things a little easier at her work, restart her home exercise programme and take some over-the-counter analgesia. She then felt fine. Lisa believed that the heavy manual handling she had done in her 20s had caused irreparable damage to her back. I didn't challenge that belief, although I am in conflict with the current manual handling guidelines that constantly advise keep the back straight and move in ways that seem unnatural. But for Lisa, the identity of her back pain and her passion for her job were so deeply intertwined that I couldn't affect that, and I didn't want to negatively affect the rapport we had developed. When I asked her about when things started to get difficult again, Lisa explained that about 12 months ago, while helping to turn a patient, she felt a sharp sting in her back and pain like she'd never felt it before. Her back went into spasm, and as she was unable to finish her shift, she went home to recover. The next day, her back was extremely stiff, and she started to experience a vague pain in both legs. That's normal. Aware of her medical history, I asked Lisa what she was thinking at that stage. She said she'd started to worry about the referred pain. She had seen patients suffering with back-related leg pain who were now in wheelchairs. She went to see a GP, who examined her and completed a neurological assessment, decided the history indicated a simple back strain, prescribed analgesia and signed her off work for a week, asking her to come back after that time. The GP had reassured Lisa about her leg symptoms, and following the visit, her pain had eased considerably. Feeling that she was going to recover quickly, Lisa now restarted vigorous home exercises the next day, but for some reason they were making her symptoms worse. When I asked what she thought might have happened, Lisa explained that she felt she had now done some very serious damage. And on returning to her GP, became more concerned when the advice was that perhaps she needed a little bit more time off work, but that the symptoms would resolve in a couple of weeks. When Lisa returned to work a few weeks later, she was still in pain. She was put on light duties and told that she could not return to normal duties until she was 100% better. 6 weeks later, her symptoms had still not completely disappeared. She was struggling on occasions to bend to pick things up and put her shoes on. And she was increasingly reliant on her family to do things around the house. She stopped her exercise program. Lisa's leg pain became a little more erratic, but with no pattern, when some days she was completely pain-free and others were terrible. She was having trouble sleeping. She then started comfort eating and became less active. She gained weight and started to feel hopeless. Now, there's a lot of Lisas. I don't know whether you know any Lisas, but there's a lot of people who get into that spiral. And this is that spiral in a nutshell. This is the biopsychosocial aspect of managing low back pain in someone with that level of fear avoidance and that level of lack of understanding. That GP was great, but her beliefs instilled in her And of course, the work situation to be 100% better doesn't help. You wouldn't do that with a sprained ankle. So, are health and safety personnel, back care advisors and risk assessors and trainers all part of the problem? Are we? Do we think we might be? Now, what does our training include? Okay, now this isn't you. I know this is not your programme of training, but this is sometimes a programme of training. So we start by catastrophising the likelihood of injury and that this might be lifelong in order to get people to listen to us and try and do the right thing. Then, we then tell people that risk assessment is the problem. If you use this tile stuff, then we'll solve the problem. Or get someone out of a job. We then talk about tiny aspects of that postural positioning. Put your hands here, oh no, turn your wrist the other way. Put your foot here, oh yeah, but you're a different height to her. We worry about, I'm not saying that sometimes they're not important, but we stress this over and over and over again. Tiny aspects of postural position will make a massive difference. Then we list the laws. We list the laws, and not necessarily all in this order. We list the laws and the dates that the laws were. We name them all. And then we talk about tile. Then we demo. And then we get the people in the room to follow the demo on each other. And then we tick a box to say we've done it. And then we wait 12 months. And then we repeat it. And if someone's off with a back injury and coming back to work, like Lisa, they're sent on the same programme before they could go back to work. When the first item on the programme is the catastrophising about the injury that could be lifelong. Do you see how that happens? And I'm not saying it happens in your organisations. I'm saying that's the perception of manual handling training. So Dave Nolan, who has presented at conference a few times, both plenary and workshop, and is a physio, he did a survey. This is the most depressing bit. This is really depressing. It's depressing, I have to say. In 2018, and he asked back pain advisors, members of National Back Exchange, he asked back pain advisors about 6 beliefs. Did back pain advisors believe these 6 statements? Do back care advisors or manual handling trainers believe that the back is vulnerable? Do they believe that the back needs protected? Do they believe that back pain is special and not like another injury? Do they believe that activity is not safe with back pain? And do they believe that the prognosis of back pain is poor? And do they believe that there's always a correlation between an injury and back pain? Or can that just be non-specific and manageable? Oh dear, the results were really sad. Do you know what? Manual handling advisors, on the whole, held those beliefs. They believed those things. The majority of the respondents said the back is vulnerable, the back needs protected, the back pain is special and very different to other parts of the body. All negative beliefs. The same survey he then did with a series of physios, and thankfully for the physiotherapy profession, the answers were different. But that in itself is tragic. Where's the relationship? Where's the relationship between the physiotherapists who are doing that research on back pain and back pain management and the biopsychosocial effects and fear avoidance? Where's the relationship between those people and the people in the same organisation delivering manual handling training? Where's that relationship? Who helps those back care advisors and those trainers with that evidence? Who helps them to get that message correct? Or are they so ingrained in what they teach, they've been doing it for so long and it's so repetitive, they just turn it out? I hope that's the hideous view and it's not applying to anybody in our organisation, but it may be. So what approach should we take? We should focus on lifestyle factors. We should focus on things like sleep and mood and stress and anxiety, all of which increase back pain. And general health, as well as posture, good ergonomics and good basic assessment. Perhaps, more controversially, actually calling something back care management says there's a problem that doesn't exist. You know, where did the whole idea that good manual handling was about saving our backs ever come from? It's about the person. It's about quality of care. So we really got to have to question whether the whole term back care advisor is correct. Oh no, I have shut you up. Sorry. Perhaps back pain is just like getting tired, becoming sad, needs managing in a whole holistic way. So let's just talk about posture. Just a little, this is equally controversial, but I just want you to think. Neutral versus flexion. Okay, is flexion so bad? No. Okay, so we would all agree that I hope, that if we were teaching someone to do something from scratch, we'd pick the chap on the right. We'd pick the chap on the right basically because he has, as near as he can make it, a fairly neutral spine. I'm not going to stop him doing it, am I? I'm going to say, okay, you lift that heavy weight, that's fine, but just do it in the most effective way for you, the strongest way, the most efficient way. Use muscles that can do that better. Is he okay? Yeah.
Might break himself, but...
Well, no, I reckon he's got a fairly strong pelvic floor. So, what are we looking at? He's got a good grip. He's got his feet flat. He's stable. He's got his knees only at 90 degrees, and he's taking the flexion at his hip. Good? Yeah, I'm not going to say don't do that. It's too heavy. It is heavy. It's a manhole cover. He's in much the same position. So we can't say, as I said earlier, can't say to people, you go, don't do that and don't do that and don't lift. Oh my God, lifting is awful. You go to the gym? Yeah. You know, we tell the ageing population, people of my age, that, you know, the best exercise for you is weight training, it's resistance training. Oh, but are you a manual handling trainer? Oh, yeah. Oh, careful. It's people you move. These are some of the fittest people on the planet. And they're in forward flexion. If we saw someone bending over a bed like this, we'd say, oh, don't do that. How long do they spend on a bike? Hours, days. Let's be realistic about how efficient the body can be. Let's be realistic about what we can help and what we can't help. Let's not get people to worry. Let's get people to move. They're all normal, aren't they? But if you saw somebody like this chap with putting the foot plates on a wheelchair, you'd say, well, I think you could do that better. So yeah, I'm not trying to throw the baby out of the bathwater. I just want you to think about movement and about efficient movement. So, do we teach people to hinge at the hip and try to minimise spinal flexion to reduce the risk of pain or injury? Is there sufficient evidence for that? I'm not sure that there is. We think it's the best position, but the evidence is weak. We need to keep looking for that evidence. The biggest difference between those sportsmen and people who, if we're over a bed, for example, if our hands are fixed, we're actually in 4-point weight bearing. If our hands are not fixed and we're just hovering and we're then nothing to support the forward position of our spine, we're more vulnerable. But not for 2 minutes. You'd have to stand there quite a long time before you got a level of injury. Flexion is not so bad. if you're only lifting a low load or you're in a position for a short length of time. Again, you'll find that evidence there, which is a really good article, Spinal Flexion Debate, Prepare for Doubt. The message for today is to be open-minded to new research and to remove the keep your back straight and bend your knees. So we're going to replace it with. What would you replace it with?
How you are comfortable.
Yeah? I must admit, I replace it with keep your fat feet. Sorry. Keep your feet flat and stick your bottom out. Because I want people to be stable on their feet. I don't want them to go into a forefoot support. But you can do whatever. So what remains sensible? Our basic advice remains sensible, which is a wide base of support, working within our centre of gravity. Of course that's sensible. There's no real argument there. Perhaps the message should be, keep your feet flat, stick your bottom out, which keeps your spine reasonably neutral, keeps the bend from your hip, takes the flexion out of the knees. This keep your back straight, bend your knees. How many nurses do you ever hear, oh, I've not got good knees. I've really not got good knees. I can't lift properly because I can't bend my knees. Well, actually, you don't need to bend your knees. You only need to bend your knees to 90 degrees and no further. So, you need to think about that, you need to talk about that, you need to discuss that with classes. So we need to be aware of those anthropometrical differences. We're not all the same. We don't all do things the same. And we do have aches and pains and joint stiffness and lack of range of movement and all sorts of things that we need to accommodate people so they won't all look the same. And then think about that full system. Think about lifestyle. Think about change. Think about language. Think about whether you do really need to draw a picture of the spine and every vertebra and talk about the disc being like a Swiss roll or whatever you use. We need to think whether how relevant is that to exactly what they're doing in their day-to-day job, or are you highlighting something that actually creates a problem that's not there in the first place?
I had a lot of trainers the other week, and there was a trainer update, and I said, forget donuts, because he was telling me about donuts. He said, oh, we always bring donuts to the training. I said, well, no more donuts, because that's what they were using.
Yeah, I know. And but it's historic, and it's ingrained, and it's creating the wrong perception.
I think that's part of the problem, Pam. Historically, when you go on a trainer course and you become a moving and handling trainer, what you learn, what's the first thing you learn about? Well, then you learn about the anatomy of the spine, and that's still that training program hasn't changed.
Okay, so I would challenge the why. Why hasn't it changed? You do need to buy upset. Not that I'm talking about. Okay, so we need to concentrate on the full system, the correct use of equipment for the correct job, and the correct attitude to managing what is a normal part of life. Nearly every one of you has had back pain. But none of you is putting your hand up and saying to me, oh yeah, but I'm completely disabled by my back pain. You get over it, you do get over it. And if it's like Lisa and it comes back every so often, you learn coping strategies. Keep your feet flat, stick your bottom out. So I just want you to challenge what you teach, challenge what you say, challenge your answers to other people when they ask you. Challenge this whole back care management thing. I'm not saying there is no repetitive injury. I'm not saying that it isn't an issue. I don't want to reinvent the wheel. I just want to challenge so that people have a different attitude. So we've actually got more money to spend on cancer and diabetes. And the resources, that's one fact that terrifies me. The other fact that terrifies me about the NHS, and there's many, one is that, do you know how much money, there is more money spent on litigation in the NHS than there is on drugs.
Some startling fact is that the litigation cases that are in the pipeline is that you could build something like 8 new hospitals.
Absolutely. There is more money spent on litigation and defending litigation than there is the drugs bill for the NHS. And a lot of that, well, no. The majority of that, funnily enough, is obs and gynae. But the next one to obs and gynae is back pain. Healthcare professionals, health and safety experts have a considerable influence. You are huge in people's back pain beliefs and challenging those back pain beliefs and teaching them. We can have an enduring impact, and we need to use that influence well. Perhaps we need greater education. Perhaps we need to think about MSDs in a different way. Perhaps we need to talk more to physios and people who look at the human movement away from pure technique-based movement and handling. Perhaps we need to understand all of that a bit better. Perhaps we need to link that a bit more. We need to look at MSDs in a different way. We need to think about the sprained ankle. We need to talk to employees, help them come to work, understand that they may be hobbling for a little bit, but they will get better. So swim against the tide. Go back and challenge what might be just a routine delivery and think how you could change that, even in some small way. Break the ice. So the chief executive of NICE said in 2019, just 6 months before the pandemic, if the United Kingdom's 5.7 million small and medium-sized businesses encourage their workforce to be more active, if that was their focus, they are more likely to reap the benefits of having engaged employees who are more productive and less likely to take time off sick. So if hospital trusts, if large nursing home chains, if community care agencies provided more cycle storage, I don't know, showers, changing facilities, mental health awareness, talking therapies, Pilates, yoga, we're doing some yoga tomorrow, I believe, spin classes or gym membership, lifestyle, weight management and nutritional advice. There are organisations who have health and wellbeing benefits for their staff. Do we link those to our movement and handling programmes? And if not, why not? Do you explain what those benefits might be, how people can access them, how people can get help for weight management, cessation of smoking, lifestyle changes? That's what the stuff in movement and handling training should be. Just a new way of thinking. That's a very similar poster to the other one, and it works really well. Pain does not usually equal damage. I can trust my back. Back pain needs movement and a graduated load. It is safe to bend. If it hurts, relax, breathe, and move normally. Fun activities are best. Back pain is not all about the scans. Lifestyle factors are the most important. Movement and loading makes backs strong and healthy. Thank you. What have you got to say? What are the things you'll take away from that? What are the things that you'll either come back and challenge me about or others, or something that you will take back to change or adapt or think about or change your training? Any feedback?
I think it's really looking at, as you said, with the training, to go back and look at some of the PowerPoints I know I have at work and take out some words. I know. And like you said, I like your passion of challenging what is there. I mean, I attended, I think, the last National Back Exchange, and I remember I picked something, I think it was another physiotherapist that presented a case about the convention that when you need to roll somebody in bed, the head of the bed has to be flat, you know, and people dip in and try to bring people forward to do that. And I always believe in the why. If you understand the why,
Absolutely.
then you
Just that
remember-
sentence,
yeah,
just that
why.
sentence, in order to roll somebody, whatever it
Yeah.
was, the bed needs to be or has to be flat.
Right.
It doesn't.
It depends.
You put your head up, it changes your pattern of movement.
Of course it does. What were you going
I was just thinking that we work for quite a small organisation, and there's a big drive for wellness and mental health support. And I was just thinking that perhaps as back care and manual handling advisors, we should link in with them.
Absolutely. That would be a really good way forward. Because that's what it is. If you think Lisa, if she'd had input from that sort of well-being, wellness, good advice, she had it from her GP, she just didn't believe it. And then she didn't get that supported back in her workplace. Anybody else?
I think that's really important. It's perceptions and it's the language that you use. One of the last ladies I dealt with in my previous trust worked in theatres, and she'd hurt her back. But her report was, I was sent to do portering duties for 2 whole days. And I said, what do you mean portering duties? She said, portering duties. I said, what are portering duties?
Yeah.
She said, I was sent to collect patients from the ward on a bed. And I said, it's not a portering duty. It's actually the first line in your contract as an engineer, but I said, it's not a portering duty, it's just a pushing and pulling activity. But in her mind, it was heavy portering work.
Absolutely.
And sometimes it's perceptions and the language.
It is,
and words.
absolutely.
Can I ask, what would you change the title to?
That's a very good question. I don't know.
Get your fat feet on as well.
You mean the title of back care advisor or back care management? I don't know. It's something I've sort of tried to think about, because it's something about quality improvement. It's something I want to desperately want to shift movement and handling from a health and safety question to a quality of care question. Because it is. Every time you put your hands on somebody or you help them to change position or transfer, you are delivering part of their full care package. Now, of course, because of the pack of legislation back in '93, very long time, then it sat with, because manual handling operations regulations were part of a health and safety pack, it still sits in the health and safety block, sorry. But now, the patient, wherever you work, the person, the service user, the guest, the patient, the movement of that patient is no longer inspected or legislated by an HSE, the employer is, but the person is now looked after by CQC. So that's about care quality. So we've really got to think about where we sit in that balance. Now, in some trusts and organisations, movement and handling training is workforce development, management, health and safety. And in other organisations, it's clinical governance, nursing-led, or therapy-led, or HAP-led. So that, wherever you sit in that balance, changes where movement and handling sits within your organisation. I'm not trying to evade the question, well, I am really. Because if you were working in this group, you'd be called something different than if you were working in this group, just because of the history and development of the organisation who's employing you. So I think we have to try to find a job title, or we have to try to argue for our own job title within our organisation that better reflects what we're trying to do.
I think even that terminology though, manual handling, still has that connotation.
Yeah.
with
Yeah.
health and safety,
We've
whereas
changed
moving and
ours.
handling advice.
So what do you call that?
Moving with dignity.
Yeah.
We changed moving and handling.
I mean, we are movement and handling practitioners. That's what we are. But whether that's that and that back care title is gone from that, but it's still there in many other areas. And that's a slow change. That's but it does give this perception of what or who we are.
Did you say we could use some of the posters that you...
Yeah. They're all available. The references for the posters are on the presentation. So when you get that, you'll be able to click on those.
And we can use them.
Yeah, go Well, they're out there, but they're not. This isn't the Pam Simpson thing, you know. It is all evidence-based. Anybody else? I have no idea what the time is. I think that's about
It's
right.
down for my, it's the final break now, so.
I think that's it.
Yeah.
That's it.
That's it. Goodbye!
Bye.